Hello everyone. Today we talk about prolonged second stage of labor. It's that stage of labor where the risks for the fetus and mother are so high if it's mismanaged. So I decided that we talk about that today. So the objectives of our presentation today is just to understand what second stage of labor is, how delay in this stage of labor differs from delays in the other stages, and finally how to manage a prolonged second stage of labor. So as usual, we start with our definitions. What is second stage of labor? So second stage of labor is that stage in labor from full dilatation to delivery of the baby. And normally we would say the second stage was normal if the fetus or the baby is born with no problems and the mother also goes unscathed. That's what we would normally call a normal second stage of labor. We know that second stage of labor has two phases. The first phase, which is the time when a woman is fully dilated, but there's no maternal age to push. And then we have the second phase where the woman is fully dilated and there is maternal age to push. So how do we define a prolonged second stage? So there's several ways of defining a prolonged second stage. One of the ways is to say that we'll define how long the first phase of the second stage of labor should last, which is usually like an hour or two, and then the second phase of the second stage of labor should last about an hour. So the total is about maximum 3 hours, if we put it like that. Then we can also define it according to the parity, and we know that in nulliparous women, second stage of labor usually lasts about 2 hours. In multiparous patients, it should not last more than 1 hour. In patients who have had an epidural, second stage of labor would even last up to 3 hours. We don't usually do epidurals in the government hospitals. The important thing to remember is that second stage of labor, like every stage of labor, is variable from woman to woman, and therefore we need to concentrate on looking for morbidity for the fetus and looking for any abnormalities that would make us intervene. One last point on the definition is that we need to remember that prolonged second stage of labor is not the same as obstructed labor. So we can look at the video on obstructed labor that we already have. So the World Health Organization has removed a lot of clutter in the definition of postpartum in the definition of prolonged second stage of labor. So they are not looking at whether you have a epidural or not. They are not looking at whether how long the first phase of the second stage of labor is, how long the second phase of the second stage of labor is. They just simplify it and say that second stage should not last more than 3 hours in prime gravidas, and it should not last more than 2 hours in multigravidas. Locally, second stage of labor is 1 hour in multigravidas and 2 hours in prime gravidas. So that's the local convention that we are using. But like I said before, we need to remember that second stage of labor, the duration in itself varies from woman to woman. So how do we manage a prolonged second stage of labor? So one thing we need to remember is that prolonged second stage of labor usually means fetal distress many times. So we need to make sure that we prepare for resuscitation. The resuscitator is ready, it's warmed, the oxygen can flow there, and everything else. Your ambubags are working, your suctions are working, and all such things in preparation for the resuscitation. We need to reassure the woman that she'll be okay. You get amazed how much encouragement of women can contribute to what has been diagnosed as prolonged second stage of labor. Just telling the woman what she needs to do, hold her legs, lift up her head, think of herself as she's pushing stool. Most prime gravidas with that information get to learn how it should be done, and most women have delivered like that. We need to make sure the bladder is always empty. The bladder gets in the way of the delivery, so if the bladder is empty, we facilitate delivery. We need to remember that the laboring position that we like a lot, which is lying on the back, is not the ideal position for laboring for a prolonged second stage. So it's important that the woman tries other position, because labor is really, especially second stage, there's a lot of mechanics going on there. A change in position can change the way the position of the baby is in the pelvis and can aid the delivery. So they can try to be on the all fours position. They can try to squat and try to push out the baby. You'll be amazed how change in position can change the outcome. Then, of course, we need to, if we've decided that it's just the maternal tissues, the rigid maternal tissues in the way, in that instance, an episiotomy would be obviously of help. An episiotomy is of course of help as well if we are doing any instrumental delivery and so on. So during this period, we need to make sure that we are watching contractions, because if the contractions disappear, that could be a ruptured uterus. We need to check the blood pressure and the pulse. All these things would show us that something has gone wrong. We need to check how the labor is progressing by doing vaginal exams about hourly. We need to check the fetal heart usually before, during, and after a contraction to just see how the fetus is coping with the strong contractions that are usually associated with a second stage. We've already said that the big thing about second stage, prolonged second stage management is finding out why the second stage is prolonged. So it could just be the patient herself. She does not know how to push. She's not aiding the pushing properly. So with encouragement, with proper positioning, with teaching the techniques of breathing and pushing, a patient might end up just delivering without any interventions. And as we've already said, if the maternal tissues are rigid, then we can do an episiotomy to aid the delivery. The other cause would be the passenger. So we are talking about malpositions, malpresentations, a big baby. All these would cause a prolonged second stage. So if it's a malposition and a malpresentation, sometimes we wait to see, especially if the fetus is okay, the mother is okay, we could wait and see if the labor progresses. Otherwise, if there are signs of obstruction, we take the patient for cesarean section. The other cause could be the pelvis, a contracted pelvis. We cannot do anything about a contracted pelvis. So if the pelvis is abnormal, the baby is so big, we go for cesarean section. And then the last one, this has been put there really to make the point, and it's at the bottom for a reason, which is that most prolonged second stages are not due to contractions. For a woman to reach full dilatation, it usually means they have adequate contractions. And when labor is prolonged in the second stage, we need to look beyond contractions to explain the delay. So really the giving of oxytocin, augmenting labor in a prolonged second stage is not advisable, because there's a reason why that second stage is prolonged. That if we give oxytocin, then we end up causing fetal distress. We might end up causing ruptured uterus, because how did the woman reach the second stage? And that second stage is even prolonged if she had inadequate contraction. So in our assessment of finding the cause, we need also to assess if we can do an operative vaginal delivery. So we are looking for an empty bladder. We are making sure that the presentation is cephalic. We are making sure that the woman is fully dilated, the membranes are absent. We are making sure that the descent is good, that the presenting part is engaged. The station is at least below 0. And we need to look at the facility where we are. Is it able to provide the cesarean section, and do we have competencies to do an instrumental delivery? If all these are in place, then an instrumental delivery can be done. If we do not meet these prerequisites for having an instrumental delivery, it's better to refer a patient to a place where cesarean section can be done, or if cesarean section can be done in that facility, the patient should go for cesarean section. So just to emphasize, do not augment patients with prolonged second stage of labor, especially multiparous patients. You do well just to wait and give a patient time if maternal and fetal well-being is assured, because we'll end up with ruptured uteruses, we'll end up with worsening fetal distress. So the emphasis is that we are better off waiting to see if a woman delivered, if the baby is okay, if the mother is okay, other than augmenting labor in a prolonged second stage. I think that was the last point on the management of a prolonged second stage of labor. Thank you so much for listening, and we will see you in the next presentation.